Welcome to the Acute Medical Teaching Series. We are your hosts, Shifona,
and Harrison.
both senior house officers from Salisbury District Hospital.
This is a 12-part teaching series running over the next 3 months. You can find links to the other sessions on our YouTube channel or via Blackboard for the local Southampton students. This is our 8th session and we'll be looking at acute kidney injuries today.
So what is an acute kidney injury? It is an acute impairment in renal function with associated rise in creatinine and urea with a fall in urine output and eGFR. It is estimated that AKI is seen in 10 to 20% of hospital admissions, with an associated mortality rate of more than 20%. 7% of patients admitted with AKI will require renal replacement therapy.
AKIs have a wide variety of causes, which can generally be divided into 3 groups: pre-renal AKIs, intrinsic AKIs, and post-renal AKIs, which we will now go over. We know that 80% of cases of acute kidney injuries are secondary to a pre-renal AKI. This is a result of impaired perfusion to the kidney in the cases of shock. So for example, if the patient is bleeding, if they have a systemic infection such as sepsis, if they have diarrhea or vomiting, or if they have heart failure in the form of their heart not pumping adequately to the kidneys. In a pre-renal AKI, there is an appropriate physiological response to the dehydration, as the actual function of the kidney is not impaired. There is activation of the RAS system, leading to sodium and water reabsorption in the kidney, and this subsequently treats the dehydration, and it also leads to vasoconstriction, treating the low blood pressure. This leads to a classical picture of a low urinary sodium level, as the kidney is secreting less sodium as it tries to hang on to water, and a high urinary osmolality as the urine becomes more concentrated. We then move on to intrinsic AKIs, and this is where there's actually impaired function of the kidney, secondary to disease within the kidney itself. There are multiple different causes, which include acute tubular necrosis, which we'll go over later, nephritises, so things such as glomerulonephritis or minimal change disease, vasculitis, renal thrombosis, hemolytic uremic syndrome, and thrombotic thrombocytopenia purpura, and also nephrotoxins. The most common of these is acute tubular necrosis. As the name suggests, there is an acute necrosis, meaning death of the tubular epithelial cells within the kidney, which are responsible for sodium and water retention, as we previously covered in the pre-renal AKI. Because of the death of these cells, there is therefore excessive secretion of water and sodium from the kidney, and this classically then leads to a high urinary sodium, as your kidney is secreting too much sodium, and a low urinary osmolality, as your urine is not concentrated enough. Now we know an acute tubular necrosis can be to a very severe prolonged pre-renal AKI, where ischemia kicks in and the kidney starts to die. It can also be triggered by nephrotoxins. So for example, in rhabdomyolysis, you get the breakdown products of muscles. This then lands in the kidney and causes an acute tubular necrosis. But also medications we can give, such as gentamicin, contrast, and NSAIDs, can also have a similar effect.
Looking into post-renal AKIs, obstruction of the outflow of the kidney leads to back pressure into the kidney, resulting in decreased filtration and ischemic injury. This can then trigger an inflammatory response within the kidney, resulting in tubular injury and fibrosis. This includes causes such as tumours, strictures, renal calculi, urinary retention, and prostate enlargement. In the photo on the right of your screen, you can see an obstructing kidney stone in the left ureter. So how do we define an AKI? You must have one of the 3 following criteria: an increase in serum creatinine by greater than or equal to 26, an increase in serum creatinine to more than or equal to 1.5 times baseline, or a urine volume less than 0.5 mils per kilogram per hour for 6 hours.
You can also stage the AKI based on the degree of the creatinine rise. So if you have a 1.5 to 2 times your baseline creatinine rise, this is a stage 1 AKI. If it's 2 times to 3 times, this is a stage 2 AKI. And if it's greater than 3 times, it is a stage 3 AKI.
So what are the clinical features of an AKI? We would often see hypertension, reduced urine output, or any identifiable cause of an AKI. For example, sepsis, hypovolemia, nephrotoxins, recent surgery, renal colic, or symptoms of prostate enlargement.
We could also see some of the more serious complications of an AKI. For example, we could see a fluid overloaded patient, we could see a confused patient secondary to uremia, and we could also see evidence of cardiac arrhythmias.
So how would we go about working up someone with a suspected AKI? We would do some basic bloods, including full blood count and U's&E's, to check for the degree of AKI and potassium levels. We would also do a VBG to check for lactate, pH and bicarbonate levels, as well as LFTs and CRP. We could also do a urine dip to check for protein or hematuria as a clue to any intrinsic or obstructive renal disease. We could also do an ECG to check for any complications, for example, as caused by hyperkalemia.
We could also check a CK level if we're suspecting that rhabdomyolysis might be the cause of their acute kidney injury, for example in a patient who's had a long lie on the floor or a patient who's had a seizure. We could also do a chest x-ray. Not only would this provide information regarding if they have an infection on their chest, which may be driving their AKI, but it can also show evidence of pulmonary edema as a potential complication. We should also do blood cultures, as we know that infections are a common cause of AKI. We could also do urine cultures if there's suspicion of an infection of the urinary tract, for example if we were querying a pyelonephritis. We should also do urine output monitoring in these patients, and we should consider a catheter if the benefits outweigh the risks. If we are querying an obstructive cause of the AKI, we can also consider imaging of the urinary tract symptom, for example by doing an ultrasound KUB. We should also consider more niche investigations if we are querying an intrinsic renal disease. For example, if the patient has an underlying rheumatological diagnosis such as lupus. We can send antibodies for ANCA, GBM, dsDNA, and ANA, and we can also check other blood tests such as complement levels, cryoglobulins, and we could do a myeloma screen. In these patients as well, we often do daily weights to assess if there's any fluid overload, and we often do daily U&E monitoring.
So how do we go about initially managing an AKI? Assess their volume status, and if not fluid overloaded, we would give IV fluids, hold antihypertensives or diuretics, and consider vasopressors if the patient does not respond clinically. For fluid resuscitation, if the patient has a high potassium, 0.9% sodium chloride is preferred due to its lack of potassium content. However, if the potassium is normal, then Hartmann solution can be given due to risk of hypochloremic metabolic acidosis with excessive use of normal saline.
We should also stop any nephrotoxins, so this includes medications such as ACE inhibitors, angiotensin receptor blockers, diuretics, antihypertensives and NSAIDs, and also antibiotics such as aminoglycosides, for example gentamicin. We know these medications are nephrotoxic and therefore will worsen an AKI, so they need to be held. We also need to review the drug charts of these patients for their other medications. We know that lots of medications are excreted renally from your body. If your eGFR has changed, that means you may accumulate certain medications and then therefore may suffer adverse side effects, for example opiates or lithium. Therefore, we need to carefully check their current medications to ensure they are dosed appropriately.
We would also need to treat and monitor for complications. For example, hyperkalemia is a common side effect of AKI. Treatment of hyperkalemia is something we'll be covering in a later video.
If you are suspecting a severe infection, you can treat with antibiotics, fluids and oxygen therapy, as we would do in the sepsis 6. Also, if you suspect an obstructive cause, for example an obstructing renal calculi, you should order imaging of the renal tract, and you may need to involve surgical specialties such as urology for urgent interventions such as nephrostomies.
What are the indications for emergency renal replacement therapy on ITU? Refractory hyperkalemia, so a potassium of more than 6.5, refractory metabolic acidosis, so a pH of less than 7.15, or refractory volume overload with or without pulmonary edema. Other indications include end organ complications of uremia, for example pericarditis.
We would also consider emergency renal replacement therapy if the AKI is secondary to poisoning or a drug overdose, for example a lithium or aspirin overdose. Thank you for attending our teaching sessions today. I'm Harrison.
And Shifona.
See you next time.